From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Trichloroethylene is a clear, colorless, non-flammable liquid, organic chemical, often known as a carcinogen. Today, we are discussing its association with Parkinson's disease among service members at Marine Corps Base Camp Lejeune. I have lead author, Dr. Samuel M. Goldman, joining me today. Dr. Goldman is a professor of medicine at the University of California, San Francisco School of Medicine. His research endeavors focus on environmental risk factors for Parkinson's disease and other neurodegenerative disorders. Welcome to the podcast, Dr. Goldman.
Thank you, Dr. Armand. I'm happy to be here.
So can you tell our listeners more about trichloroethylene? What did we know prior?
We don't know a lot historically about the association of trichloroethylene and Parkinson's disease. There's more human epidemiology regarding the association of trichloroethylene and various cancers. For Parkinson's disease, there have only been a couple of published studies prior to our work in the Camp Lejeune population. There was a small cluster reported by Dr. Gash in Kentucky, I think it was 2008, and they found that there were 3 individuals with Parkinson's disease who had worked together in a small manufacturing plant, and that 15 or so of their coworkers had mild neurological signs and symptoms suggestive of mild Parkinsonism. So that really got us looking at this issue. And that spurred us to conduct a study in a twin population that we had been following for a number of years. The advantage of twin studies is that when you compare identical or fraternal twins, you compare their frequency of Parkinson's disease and you look for whether they're concordant, both have the illness, or they're discordant, only one has it. It can really help to tease out environmental from genetic determinants of disease causation. And so we had this population of twins, and we had conducted very thorough, lifelong occupational histories in these men. They were all men, veterans of World War II. And we inferred, with the help of an industrial hygienist, whether they had been exposed to trichloroethylene or tetrachloroethylene. So trichloroethylene I'll refer to as TCE, tetrachloroethylene as PCE or perchloroethylene. So we had 99 pairs of twins who were discordant for Parkinson's disease. And we found that in the twin who had worked with TCE, they had a 6-fold increased risk of having Parkinson's disease relative to their co-twin. There were also a handful of case reports of people who had worked with trichloroethylene over the past 40 or 50 years, maybe 3 or 4 case reports, and that was it. There were these 3 cases in Kentucky. There were a handful of case reports, and then there was our study in 99 twin pairs when we only had 10 or 12 exposed individuals. So it was suggestive, the epidemiology, but the numbers and the power is really limited. And so that's what spurred us to look at this relationship in the Camp Lejeune population.
Can you tell us a little bit about Camp Lejeune? What issues came up there for these service members, and what was the significance in terms of utilizing this for the study?
Camp Lejeune is a very large Marine and naval base in North Carolina. Approximately a third of all Marines undergo their training at Camp Lejeune. And its notoriety more recently relates to very long-term contamination of its residential water supply with a number of volatile organic compounds. The highest concentration was for TCE, trichloroethylene, where during the 70s and early 80s, it's estimated that the median levels of TCE in the water at Camp Lejeune was something like 70-fold above the EPA's maximal contaminant level. And this contamination, to some extent, probably existed from the early 1950s until the mid-1980s.
Such a prolonged amount of time. Wow.
It really is. It's one of the best documented large-scale contaminations in U.S. history.
As I was looking into the background about this, I did notice that this has increasingly been a significant topic because I know in 2017, the U.S. Congress and Veterans Administration, they deemed Parkinson's disease a presumptive service-connected condition. So those individuals serving between that large amount of time you just discussed are eligible for benefits as they develop these symptoms and are officially diagnosed. So tell us about the setup of this study that you conducted with your colleagues.
The study was possible to conduct because the Agency for Toxic Substances and Disease Registry, the worst acronym in all of government, ATSDR, wonderful organization, that's a division of the Centers for Disease Control, the CDC. They had done a lot of investigative work in Camp Lejeune, going back 15 or even 20 years. ATSDR did a lot of work to estimate the levels of the various contaminants and when they were particularly elevated at Camp Lejeune. And they had put together a very large cohort that identified everyone who had been stationed at Camp Lejeune between 1975 and 1985. In order to do the types of studies that we did, they also identified a matching population that was stationed at Camp Pendleton in California during the same time frame, 1975 to 1985. And the water at Camp Pendleton, as far as we know, was not contaminated with volatile organic compounds like they were at Camp Lejeune. So ATSDR provided those cohorts to us, and that allowed us to do the case finding for Parkinson's disease in both of those camps. And there were about 200,000 individuals at Lejeune and at Pendleton. So it was a very large cohort, which is what's needed for a relatively rare disease such as Parkinson's disease, especially given the age of the individuals at these camps. Currently, their age is around 59, median age of the cohort. So not a super high risk age for Parkinson's disease, but because of the very large size of the cohorts, we had a lot of statistical power to look at this association.
Now, let's get into the numbers. So you had roughly 150, 160,000 veterans that were in the study?
Right. So we took these 400,000 individuals that ATSDR provided us with from the two camps, and then we linked those with health data in both the Veterans Administration electronic medical record and Medicare. And we searched for all diagnostic codes for Parkinson's disease, for other forms of neurodegenerative Parkinsonism, and for medications. And then we reviewed all the medical records that we found to confirm that it was in fact Parkinson's disease, because Parkinson's disease can be somewhat of a difficult diagnosis, and also to confirm the date of diagnosis.
And what did you find?
We found a total of 430 individuals with Parkinson's disease combined at the two camps. Substantially more of the people with Parkinson's disease had been at Camp Lejeune. So 279 at Camp Lejeune and 151 at Camp Pendleton. And when we adjusted those numbers for a variety of other variables, we came out with a risk estimate of 1.7, or a 70% higher risk of Parkinson's disease in persons who had been stationed at Camp Lejeune during 1975 to 1985.
That's pretty significant.
It was highly significant. The p-value was very small, clearly significant, statistically that is. But we also did a lot of additional analyses to ensure, or to at least maximize the likelihood that this was in fact a true relationship and not a facsimile of our ability to identify people with Parkinson's disease more readily in the Lejeune group than in the Pendleton group. We spent a lot of time trying to eliminate potential biases, study biases, and confounding, which are problems in these types of epidemiologic studies.
Was there any risk that was increased in the Camp Lejeune population versus Pendleton as it came to other neurodegenerative Parkinson's disease spectrum disorders?
No, we did not see a higher frequency of some of the other forms of neurodegenerative Parkinsonism. And that was scientifically reassuring to us because the fact that the increased rate for Parkinson's disease that we saw was specific to Parkinson's disease and not to some of these other so-called atypical Parkinsonisms gave us greater confidence that this was a true biological relationship and not a biased ascertainment of people with Parkinson's disease.
Before one is diagnosed with Parkinson's disease, there can be a number of symptoms that develop. I know that in your study you referred to these as the prodromal Parkinson's disease symptoms. Was there a difference between Camp Lejeune and Camp Pendleton in terms of those symptoms developing early on? Was there a greater burden of them in the Camp Lejeune population versus the Camp Pendleton population?
Parkinson's disease has a long developmental phase. We think that the pathology, the disease process is ongoing for many years before it's actually diagnosed clinically. And we know that there are constellations of other symptoms that are present before Parkinson's disease. It's called prodromal Parkinson's disease is what it's referred to in the scientific community. And we did, in fact, find higher rates of many of the prodromal features of Parkinson's disease. So we found higher rates of tremor, of erectile dysfunction, anxiety, borderline increased risk of depression, and though it wasn't significant, higher rates of impaired olfaction, which is a very specific and sensitive finding in early Parkinson's disease. Two main points about that. The first is that that's very supportive of our observed association with Parkinson's disease. And as I mentioned, the cohort is still relatively young. They're just now kind of entering the high-risk years for Parkinson's disease. They're getting into their 60s now. Because the cohort's relatively young, we can dramatically increase our statistical power by studying these prodromal features. So that is one reason we studied them. And another reason we studied the prodromal features is because, as you pointed out earlier, in 2017, the Veterans Administration determined that Parkinson's disease was a presumptive diagnosis for individuals who served at Camp Lejeune, and that they became eligible for benefits if they had Parkinson's disease and had lived in Lejeune between 1953 and 1987. So after 2017, people who had been at Lejeune became much more aware of the contamination and became aware of the potential for getting monetary benefit. That can really throw a wrench into epidemiology because what it does is it increases the probability that we're going to identify people with PD who are at Lejeune relative to those who are at Pendleton. But with the prodromal features, there is no financial benefit for people to be diagnosed with, for example, constipation or erectile dysfunction or depression. So those are not likely to be impacted by the knowledge that Parkinson's is a presumptive condition and that there are benefits related to that from Lejeune. So we think it's much less likely to be biased by that epidemiologically. And so we were very encouraged, I guess, to say that it enhanced the likelihood that our observations were not being biased by this recognition in the Lejeune cohort.
Mm-hmm. Did you find any difference in the demographics of individuals who develop Parkinson's disease at Camp Lejeune versus not?
we found that African American and to a lesser extent Hispanic individuals were less likely to be diagnosed with Parkinson's disease, irrespective of which camp they were at. And in fact, among Black veterans, the risk was substantially lower. I think it was only around a third of the rates that we were seeing in white veterans. And we're not the first to observe that. That's been observed often in a variety of study populations. One concern when you see something like that is that it doesn't reflect a true lower rate of Parkinson's disease in people of African descent, but what it reflects is a lesser likelihood of getting the diagnosis correctly, or perhaps lesser access to health care. And that's always been one concern with that observation. Within the VA, one would presume that there is relatively equal access to healthcare. And so it increases the likelihood that there truly is a lower risk of Parkinson's disease in people of African descent.
Yeah, definitely many factors can contribute to that, obviously. But yeah, I thought that was pretty interesting. Now, when I look at these results and extrapolating this to patients that we see in the office, I might get the question of, okay, so where is TCE found? Should I be worried about TCE today? And how can we counsel patients on this, individuals who are worried about the future? And should I be worried about TCE in general?
Don't worry, because it doesn't help. But if it motivates people to improve their environments, then okay, a little bit of worry. There's a lot of TCE in the environment. It is used less in industrial processes than it used to be, and it used to be in all sort of commercial products. It was in carpet cleaners and spot removers, and it was used to decaffeinate coffee until 1977. It was even used as an obstetrical anesthetic into the 70s. So those uses are gone. But it's still used a lot for degreasing of metals in industry and as a precursor for various chemical product manufacturing. So it's still used, but more importantly, it's in the environment from prior uses, as it was in Camp Lejeune. So the TCE got into the water in Camp Lejeune because it was being dumped from an on-base site, just being dumped out back, and then it got down through the groundwater and got into the well. There are a lot of water systems that have detectable levels of TCE, though the levels are generally quite low. A bigger concern, and one that maybe we have less control over, is the fact that TCE is in the subsoil in a lot of areas, and people are unaware of it. It's gotten there from years ago, maybe an old dry cleaning establishment, maybe some industry where they used it for some process. And long ago, it got down into the soil. And then once in the soil, it's very persistent and it can travel in what are called plumes. And there are TCE plumes throughout the US. You can go to the EPA website and look and see precisely where TCE plumes are located throughout the US. And like radon, TCE can enter homes through the foundations if there's contaminated soil underneath homes. So that's another potential source of exposure. And believe it or not, TCE is detectable in many foods today. The levels are low, but it is out there. And I think it behooves people to educate themselves about their local environments, their local water supplies, and make sure that they're not at risk from this. I do think that the levels out in the environment, by and large, are low. And we always say in toxicology, the dose makes the poison. So less is better.
Do you have any closing thoughts about your study and what's next in terms of your research on this topic?
There's really has not been a lot of human epidemiology studying the relationship of TCE and Parkinson's disease. So I think the importance of this study is that it confirms the observations of some of the earlier smaller studies and case reports, and it adds to the total body of evidence. And when we try to determine causation, right? So in epidemiology, association is not the same as causation. So we have association, clearly, with a 70% highly significant increased risk. And increasingly, we are getting the evidence that is needed to establish that this is indeed a causal association. And that is supported by a lot of the relatively recent studies of TCE in animal models, where TCE given to rodents can cause a motor disorder reminiscent of Parkinsonism, and it causes a very specific degeneration of neurons in the substantia nigra and striatum. So exactly the neurons, the dopaminergic neurons that die in Parkinson's disease. And TCE produces this model in rodents. And we think that this may be directly due to a metabolite of TCE in the body called TACLO that is known to be a very potent mitochondrial poison. And mitochondrial function is thought to be an important mechanism in the etiology of Parkinson's disease. So I think this study is another large block in building the wall of causation for TCE and Parkinson's disease. I certainly hope that the Lejeune cohort will continue to be followed and studied because, as I mentioned, they're just now entering the age range where Parkinson's disease is much more common.
Thank you so much, Dr. Goldman, for joining us today.
My pleasure. Thank you, Dr. Armand.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.